All right, let us pray. Thank you, Dr. Mabel. We pray in the name of the Father, Son, and Holy Spirit. Amen. Our Lord and Master Jesus, we thank you for this evening. We thank you for a gathering like this. We ask that you yourself would direct this meeting. We ask that you grant us a serene learning time, and we ask that all of what we discuss will be to the greater benefit of children and adolescents that you have entrusted into our care. These and many other blessings we ask through Christ our Lord. Amen.
Amen. Thank you so much, Bright, for that prayer. You are all welcome once again. Um, so today, as I said, we are going to learn about neuromuscular disorders, and we have the honor to have Prof. Hammond. When I asked him to send me his bio, he sent me only one line. So I'm going to add my own. We have the honor of having Prof. Hammond, who is the freshest professor in pediatric neurology, to teach us about neuromuscular disorders in children. He is a pediatric professor in neurology at the Komfo Teaching Hospital, and he's also a lecturer at the KNUST Medical School. He has written a lot of articles in reputable journals, and he is a teacher by heart. He's always teaching, and you're going to experience his teaching today. So, Prof. Hammond, if you're on the call, we have about 103 people on the call now. Please take over. I can see your slide.
Oh, sorry, I was muted and I was talking. I hope you can hear me now.
Yes, we can hear you.
Yes. So thank you so much, Mary. Thanks to all of you for coming to our webinar. And in the next 1.5 hours, we'll be talking about muscular disorders. It's really heavily here in Kumasi. I hope the light stay on. I hope the internet stay on. But to make it easy for everyone to join, let me try my video so that the bandwidth wouldn't be.
Okay, that would be good.
Off. Okay, don't worry, I'll find it. Yeah, so as I said, in the next 1.5 hours, I'll be talking about some terminologies in neuromuscular disorders. We'll try and then localize neuromuscular disorders. As for neurologists, we like to localize. We always like to tell, is it the left or the right? Is it in the brain, or is it in the cortex, or in the deep white matter? We are always interested in localization. So we'll also do localization for neuromuscular disorders along the neuro axis. We'll talk about common presentations. We'll touch briefly on what the floppy infant is. And then we'll look at a few of the neuromuscular disorders, some common ones that we should know. And when I say terminologies, I'm just going to talk about a few terms. The first one is tone. So what is tone? Tone is basically defined as, or in simple terms, as the resistance to movement at a joint. So if you have increased resistance to movement at a joint, then there is increased tone. If you have decreased resistance, that's less than the normal, then there is decreased tone. When tone is increased, we refer to it as either spastic or rigid. of the joint.
Prof, are you still there?
Hypotonia, which
You are breaking. Have you been able to put off your video? Hello, Prof. Hello.
unfortunately, I'm sure I don't think you can hear me.
No, Prof, your network is very scratchy.
Yeah, and this is one from Elon Musk. So I'm not sure whether I should rather switch to MTN.
I think your video was still on, so now I can't hear you. So let's try again.
Now you can hear me. Okay.
Yes.
Okay. So
now I can
yeah.
hear you. Okay.
Okay. So let me start and go over quickly. So I was talking about tone being the resistance to movement at a joint. Movement, then there is increased tone, or what we call hypertonia. If there is decreased resistance, then there is hypotonia. Hypertonia can be spastic or rigid, depending on which part of the brain is generating that tone. When we say it is spastic, what it simply means is that the increased resistance at a point in time gives in. So the resistance is not throughout the full range of motion, but it gives in at a point in time. Whilst rigidity continue through the full range of motion. And usually spasticity comes from the long part, the cortex, way down to the spinal cord, or what we call the corticospinal tract. Whilst rigidity comes from deep gray matter, or sometimes what we call the basal ganglia. I will not go so much into that. Hypotonia is sometimes also referred to as floppiness, flaccidity. When we talk of weakness or paralysis, it's just decreased power. So we all know how to grade power, use the MRC scale. When the power is decreased, then there is weakness. Or plagia to refer to the degree of weakness. When we say plagia, it means total weakness, even though sometimes these two terms are interchanged. So sometimes you hear things like paraparesis or paraplegia, hemiparesis or hemiplegia, tetraparesis or tetraplegia. So when we talk of neuromuscular disorders, I told you about localization. So the disorder could be as a result of an insult or injury to the brain, to the spinal cord, to the anterior horn cell. The anterior horn cell is more like the distance at the junction between the spinal cord and the peripheral nerves. And then you can also have injury to the peripheral nerve. You can have injury to the neuromuscular junction, which is the junction between the nerve and the muscle. And then you can also have injury to the muscle itself. And in some conditions, in some neuromuscular disorders, you can't really pinpoint a particular location, and that we say it is generalized. I hope you can still hear me. Hello, Marilyn.
Yes, please, we can hear you.
Okay, thank you very much. So let's take a brief warm-up quiz. This one, you just answer it on a sheet of paper by yourself so that you are the only one who knows which answer you chose. So the question says that, true or false, the following neuromuscular disorders are correctly matched with their sites of lesion. So just circle true or false by a small sheet of paper by yourself. So myasthenia gravis has been matched neuromuscular junction, true or false? Guillain-Barré syndrome with anterior horn cell, true or false? Duchenne muscular dystrophy by muscle, true or false? Spinal muscular atrophy matched to spinal cord, true or false? Congenital myopathy has been matched to muscle, true or false? Charcot-Marie-Tooth disease has been matched to peripheral nerve, true or false? Dermatomyositis to anterior horn cell. H, poliomyelitis to neuromuscular junction. I, botulinum toxicity to peripheral nerve. And then J, or finally, paramyotonia congenita to muscle. So we'll go through a few of these, and at the end of the presentation, we'll come back to this quiz, and then you see how well we did. So let me talk about the pattern of weakness when a particular point along the neuroaxis has been hit. So usually when the brain is a site of lesion, you tend to have axial weakness. So axial is the trunk. Okay, so truncal axial weakness as a midline. So the trunk is weak. And then there may also be generalized hypotonia. This is only in the initial stages. At the end or towards the latter stages, there may be increased tone or hypertonia. When the spinal cord is hit, depending on which level of the spinal cord has been hit, there will be paraplegia or tetraplegia. When we say paraplegia, only the two lower limbs are affected. The upper limbs are spared or relatively spared. Whilst in tetraplegia, all four limbs are completely affected. So if the cervical spine is what has been damaged, then you have all four limbs affected, or a tetraplegia. If thoracic or lumbar spine is what is affected, then you have a paraplegia. When anterior horn cells have been damaged or are involved, then you have a pattern we call proximal weakness. Proximal weakness means there is more weakness in the proximal part of the limbs than in the distal part. So if you take the arm, for example, the patient will still have some strength in the hand, but the patient will be very weak at the shoulder. That is what we call proximal weakness. So the weakness is more proximal than distal. So because the shoulder is more proximal to the midline than the hand. So that's what we call proximal weakness. And again, when anterior horn cells are involved, the lower limbs are usually more severely affected than the upper limbs. When peripheral nerves are involved, it is like the opposite of what we saw with the anterior horn cell. When peripheral nerves are involved, the weakness is more distal than proximal. When the neuromuscular junction is involved, it usually produces generalized weakness without much discrimination between proximal and distal muscle. And when the muscle is involved, it's just like the anterior horn cells. You tend to have more proximal weakness than distal weakness. So this actually is one of the things that neurologists like. We would do a lot of examination to see whether the weakness is more proximal than distal or more distal than proximal, just because we want to localize the lesion. And sometimes when we get some of these things, it helps us to say that this is a peripheral nerve disease, this is a muscle disease, or this anterior horn cell disease. So irrespective of the site of lesion, some neuromuscular disorders present with some common presentations. So in children, for example, if the lesion is early on, either in utero or early on in infancy, they may have what we call floppy infants. These are hypotonic and weak infants. I will talk a little bit about that. The child may be ventilator dependent, and then they may fail extubation. So you might think this child came out asphyxiated. And so, but usually the asphyxiated kids, often after 3 or 4 days, when the edema dies down, they gain their strength back. But this child is still floppy throughout the first few weeks of life, is dependent on ventilator. As soon as you take the child off the ventilator, the child starts to desaturate. So when you have presentations like this, begin to think that, could it be more than asphyxia? Could it be neuromuscular disease? Children who tend to have recurrent chest infections because of recurrent aspiration could also be suffering from neuromuscular disorders. And then there's something we call arthrogryposis congenita. These are children who are born with multiple contractures. They are actually born with it, which is actually a pointer to a neuromuscular disorder. The difference here is that the neuromuscular disorder started in utero. So it's started even before they are born. And so by the time they are born, they have multiple contractures in multiple limbs. Some of these children will have chest wall deformities. I'll try to explain some of these chest wall deformities. They may have some pectus excavatum, they may have a barrel-shaped chest or other chest wall deformities. And so when you see those things, also think possible neuromuscular disease. And then the most common presentation, this one is not usually the doctors who see, the parents who bring the children, is because they have delayed milestones, especially motor milestones. So they'll come because of delayed motor milestones. They may have gait abnormalities. Some may have a hemiplegic gait, a waddling or a wobbling gait, high stepping gait, etc. If you also have a history of frequent falls, that the child is falling too frequently, usually when they start to walk between age 12, 13 months to 15 months, thereabout, they should be falling. I mean, they will fall. It's normal. But if the child is 2 years and still falling frequently, you should be concerned about neuromuscular disease. And then some children are walking all right, but the moment you ask them to climb stairs or to climb the steps, they struggle. They have difficulty with stairs or steps. Those could also be pointers to neuromuscular disorders. Toe walking could be behavioral. It could be due to some behavioral conditions, but it can also be due to neuromuscular disorders. So when we have children presenting with toe walking, we should rope in neuromuscular disorders as part of our differentials. Foot deformities like flat foot, club foot, high arch foot, and others are also pointers. Some children may also have episodic weakness. They are fine in every 3 days or every now and then they have total weakness, what we call periodic paralysis. And that could also be due to neuromuscular disease. Or some may be presenting, instead of weakness, may be presenting with episodic stiffness. Every now and then they get stiff, as we might see in conditions like paramyotonia. And these are also pointers to neuromuscular disease. Exercise limitation or exercise intolerance. Most of the time when we are presented with certain things, we think about the heart. Yes, it is good to think about the heart, but let's also consider neuromuscular disease when a child cannot bear even minimal exercise. So they walk a little and then they are panting. They walk a little and they are tired. These are all pointers to neuromuscular disease. Muscle cramps or pain after exertion or on exertion. And then sometimes they may also present with cardiomyopathies. So I always say that the heart is also a muscle. So when we are discussing neuromuscular disease, we should also remember the heart. And then because of this, some muscle enzymes could also be raised abnormally. So a typical example is creatine kinase, or some books will say creatine phosphokinase. And then also ALT, even though it's a liver enzyme, it is also in the muscle. So when you have some neuromuscular conditions, these enzymes could also be very raised. Now I want to talk about the floppy infant. So this simply refers to an infant with generalized hypotonia, presenting either at birth or in early infancy. So usually they have hypotonia, and that's often how early it is will make you know whether the neuromuscular disorder is an acquired one or a congenital one. When I say congenital, I mean born with it. I don't necessarily mean inherited, because some acquired, some of the ones that we think are acquired are actually also genetically programmed, so they are inherited. But I'm talking of being born with it. So when they are born with it, they often present floppy at birth or in early infancy. And the features are that when you take your history, you may have history of decreased fetal movement. So if you have an experienced mother, a mother who is having a second child, they will be able to compare this very index chart with the previous one and tell you that the older one moved a bit more vigorously than this, and that this child was not moving so much, or sometimes the onset of the fetal movement, usually between 18 to 20 weeks gestation. But this child, as late as 22, 24, I wasn't feeling his kicks. So these are some of the pointers to neuromuscular disorders. And then some of them may also present with abnormal lie, such as transverse lie or breech presentation. So whilst we are in our mother's womb, God has programmed it in such a way that we all tend to move around. And then by the time we are at term, our head is facing the birth canal. So we are born usually with a cephalic presentation. But if a child has neuromuscular weakness, the child may not be able to move a lot. So the child may be locked up somewhere in transverse lie. Even though they are term, they may present with transverse lie, they may present with breech presentation. So when you have a child who is born transverse, who is born with breech, these are some of the reasons. It could be other reasons. It could be some mechanical reasons like uterine fibroids and or other things, but neuromuscular weakness could also contribute to these presentations. Then they may also have polyhydramnios or oligohydramnios, especially polyhydramnios. Polyhydramnios because children with neuromuscular weakness have weak swallowing. Remember that the muscle that helps us to swallow, these are all muscle. So in the womb, the child is usually swallowing the liquor. But if the child has weakness in swallowing, then the liquor will build up, and then there will be polyhydramnios. And then also when you are presented with the floppy infant, ask about clues like hypoxic ischemic encephalopathy because those could be the reasons, or neonatal seizures. And then it's always important to ask about consanguinity. That is not very common in our part of the world, but you might never know when you have a patient presenting to you from the Middle East, where sometimes consanguinity is common. So some of these autosomal recessive inheritances become very common when you have consanguinity. Hello, can you hear me?
Yes.
Okay. Something flipped on my laptop, so I thought maybe I'm off. Okay, so that's fine.
Okay.
So still continuing, in the clinical features of a floppy infant, you may have things like a weak cough. Okay, so when you take history and ask about cough, or even when the patient coughs in your presence, you might realize that the cough is weak. Everybody's cough should be strong enough. Cough is a reflex, and it is intended to bring out any foreign that has gone into the respiratory tract. So if it is not strong enough, then probably the patient has a muscle weakness, because before you cough, you take in air and you use your chest wall as your chest wall contracts sharply to bring out the air. And so if your chest wall, which is actually muscle, is not contracting strong enough, then there could be neuromuscular weakness. I've already talked about the poor swallowing. Some of these children may also be drooling, or they may be pulling secretions, and that's all because of the difficulty in swallowing. They may have a weak cry, just as they have a weak cough. And then the muscle tone may be poor, the posture may be poor, and recurrent chest infections, I mentioned that already. And then some of them may be present with what we call paradoxical breathing. Let me take a few minutes to explain what paradoxical is. So wherever you are, just try to take in air. Just try to breathe in. As you breathe in, you see that your chest comes out. But at the same time, your abdomen goes in. The reason your abdomen goes in is that when you are trying to breathe in, your diaphragm is contracting. The diaphragm contracts to flatten out. And when it flattens out, it increases your intrathoracic pressure and then helps you to take in air. But when the diaphragm contracts and flattens out, it also pulls the abdominal muscle. So that's why when you breathe in, your abdomen goes in. For children with neuromuscular weakness, they often tend to have weak chest wall, but the diaphragm is relatively spared. And so they breathe in, their breathing is more diaphragmatic. So they have weaker intercostal muscles. So instead of the chest wall expanding, the chest wall fails to expand. And so the diaphragm is the only one. The diaphragm actually pushes down more on the intra-abdominal content, increases the abdominal content, and then the abdomen rather comes out. So in children who have neuromuscular weakness, we all breathe with both the intercostal muscles and the diaphragm. We don't rely so much on the diaphragm, but children with neuromuscular weakness rely so much on the diaphragm, and the diaphragm pushes down, and instead of the abdomen coming in, rather pushes the abdomen out. So they tend to have abdominal breathing. Some books will call it abdominal breathing. Their abdomen will be moving in and out whilst their chest looks silent. But when we breathe with our chest moving in and out and our abdomen silent, unless we take in a deep air, that's when our abdomen moves. So they rather move with their abdomen more than with their chest. And that's why it is called paradoxical. So sometimes when they take in air, instead of their chest wall expanding for the chest to come out, the chest rather goes in. And that's why the term paradoxical. And when you look at the chest and the abdomen, one of them moves in, one of them moves out. So they play around like a seesaw. And so some books also refer to it as seesaw breathing. So that's the brief explanation for paradoxical breathing or seesaw breathing. A few pictures. On the first one on the left, the baby is being pulled to sit, and you see the significant headland. This is a baby who is floppy. So these are pictures of floppy infants. So you see that the head is way behind the trunk, and we call that head lag, and it is a common presentation in floppy infants. The second picture, still on the left, shows a baby who is being held in a horizontal. And you see the limbs of this baby. The limbs are straight out, and the baby is looking like an inverted U. If you write a U, U will face upwards, but this U is facing downwards. So this baby is looking like an inverted U, and that is what you get in a floppy infant. The picture on the right, this is what we call frog leg posture. So this baby is lying to the one on the extreme, and you see how the limbs are lying flat, just like a frog. So that's how come the term frog leg posture. Usually, you expect that there will be some tone to lift the limbs up a little, but here the lateral aspects of the limbs are all touching the bed, and that's an indication that you have. Again, these pictures are showing the same thing that I said. Let me talk about the last two on the right. So the one to the extreme right is a baby who is floppy, who is being held. Also, the weakness at the shoulder. They are like slipping through your fingers. So you see that this baby's, if you compare to the last but one, who has a good tone, the baby is resting their arm on the examiner's arm. They are resting their armpit on the examiner's arm, but the other one is almost slipping through the examiner's hands. So these are all indicators to floppy infants. So when you have a floppy infant, the clinical approach, all that you should be interested in are two main things. Where is the lesion located? And I'll go over the localization again so that we get it. Is it an upper motor neuron lesion or a lower motor neuron lesion? Upper motor neuron lesions will also present with floppiness in the initial stages. So when a baby has severe beta asphyxia, they may be floppy, but that is an upper motor neuron lesion because it's the brain, the cortex of the brain that has been hit. But in the initial stages, they may be floppy. Lower motor neuron lesions are always floppy. And then the second assignment is to determine whether the hypotonia is accompanied by significant weakness or not. I will explain. So sometimes you can be hypotonic but not weak. And then sometimes you can be hypotonic and weak. A baby may be lying down in a frog leg posture, and you might think this baby is very hypotonic, but you pinch him and he draws his hand. He draws his hand with you.
Prof.
With profound weakness. Hello, Marilyn.
Prof, you went away for a while.
Oh,
but
sorry.
But you are back, so.
Okay.
We'll
So let me just
continue.
go over this slide again.
Okay.
So this slide, I'm saying that we are looking at the clinical approach to the floppy infant. And we should have two main tasks when we want to evaluate the floppy infant. First, identify the lesion along the neuroanatomical axis, whether it's an upper motor neuron lesion or a lower motor neuron lesion. And I use the example of beta asphyxia, that when we have beta asphyxia, even though it is cerebral cortex that has been hit, and so it is an upper motor neuron lesion, they may present floppy. So floppiness could still be upper motor or lower motor. They present floppy in the initial stages, and with time they evolve to present with the spasticity that we see in the children stage. So always look for a site of lesion. The second assignment is to determine whether the hypotonia is accompanied by significant weakness. And here I'm saying that if you are hypotonic, you may be hypotonic, but you may not be so weak. So there are two types of patients who have hypotonia. Some have hypotonia and they are very weak. Others have hypotonia and they are not so weak. For example, you may have a baby who is very hypotonic, but when you pinch them, they will draw their leg from you. And so they are not so weak, even though they are hypotonic, whilst others may be hypotonic and will have profound weakness. When you have weakness, when you have upper motor neuron disease, profound weakness is not so common. So profound weakness is not a common feature of upper motor neuron hypotonia, except in the acute stages. But when you have hypotonia with profound weakness, it's almost always suggests lower motor neuron lesion. So I've listed a few conditions where the lesion is located. So much on the brain and the because this one also present with a lower motor neuron lesion, and then later on present with upper motor neuron lesions. A common example are corticospinal disorders like what we see is patients ganglia disorders, cerebellar disorders, stroke, and a lot of other things. These are all lesions in the brain or in the spinal cord. But you can have a lesion in the anterior horn cell. And a common example of anterior horn cell disease are spinal muscular atrophy, SMA, and then poliomyelitis. I'll spend a few minutes talking about both of them. And then with peripheral nerve, common examples are Guillain-Barré syndrome. I think we all know Guillain-Barré, GBS. And then there's another one known as Charcot-Marie Tooth disease, or CMT. And I'll talk a little bit about Guillain-Barré. When it comes to the neuromuscular junction, Typical examples are myasthenia gravis and then botulinum toxicity. When it comes to muscle disease, common examples are congenital myopathy, dystrophinopathies, which are Duchenne muscular dystrophy, Becker's muscular dystrophy, congenital muscular dystrophy, myotonia congenita, and paramyotonia congenita. You may have some inflammatory conditions like dermatomyositis. You may also have metabolic conditions like Pompe's disease or some mitochondria myopathies like MELAS. MELAS is mitochondria encephalopathy with lactic acidosis and stroke-like episodes. It's a long term, and we just shorten it to MELAS. These are due to energy or metabolism problems, and it affects mainly the muscle. And I also mentioned that some neuromuscular conditions may not have a particular location. So some patients will present floppy, such as patients with trisomy 21, hypothyroidism, or Prader-Willi syndrome, and you don't have a specific localization for such conditions. So let me spend, I think I've been talking for about 40 minutes now. Let me spend the next 20 minutes talking about 4 of the common neuromuscular conditions. Please, if you have any questions as we go on, I will encourage you to put your questions in the chat box so that we can address them as we when we get to the question time. So please, I will encourage you, just write your questions into the chat box. So now we'll be talking about spinal muscular atrophy, or what we call SMA. It is an anterior horn cell disease. It is a disease that leads to a progressive degeneration of the anterior horn cells. I told you the anterior horn cell is more like the junction between the spinal cord and the peripheral nerve, but it is not the spine. So it is not in the spinal cord. It is in the anterior horn cell. And it is autosomal recessive inheritance. What it means is that some people will be having the gene, but will not express the disease because they are just carrying it. Sorry, you express the disease if you have 2 of the genes, because it's a recessive gene, you should have 2 before you express the disease. And the gene is known as a survival motor neuron 1 gene. So it is responsible for the production of a certain protein, which we call SMN protein. This SMN protein is predominantly produced by the gene we call survival motor neuron 1. A lot of it, 90 to 95%, by survival motor neuron 1, whilst a small percentage is produced by the survival motor neuron 2. So even though both survival motor neuron 1 and survival motor neuron 2 are important, it's mainly mutations in the survival motor neuron 1 that leads to SMA. Because if you have an intact survival motor neuron 1 and then survival motor neuron 2 is hit, because it is only responsible for a small percentage of the protein, you don't really suffer the condition. But if survival motor neuron 1 is hit, then you may suffer the condition. However, survival motor neuron 2 is important for us in classifying the severity of the disease, and I'll explain why. So when survival motor neuron 1 is hit, the body has, even when it is not hit, the body in general has a tendency to have multiple copies of survival motor neuron 2 or SMN2. So if an individual has multiple, or let's say most people have about 2 copies or 1 copy, only 1 copy of SMN1. If you have only 1 or 2, and I mean SMN2, if you have only 1 or 2, and then your SMN1 is hit by this mutation, then you suffer a severe disease. But if you have multiple copies, some have 4, some have 5. If you have 4 or 5 of SMN2 and SMN1 is hit, even though SMN1, which is responsible for the majority of the protein, has been hit, you will still get a considerable amount of protein production from SMN2. And so you may have a mild disease. And so this is what actually makes SMA interesting. And it's more like a spectrum. Some people are so severe, some are mild. And so the severity of the disease is determined by the copy numbers of SMN2. So this is one of my favorite MCQ questions for my medical students. I always ask them, the severity of the disease is determined by the copy numbers of SMN2, because that is what actually determines how severe your disease will be when SMN1 has been hit. So based on that, we can have various forms of severity. In the past, they didn't know all this, and then they tried to box the severity into type 1, type 2, type 3. But there is no distinct difference between type 1 and 2. So even though type 1 is more severe than type 2, which is also more severe than type 3, some patients, you find it difficult to put them exactly at type 1, and you find it difficult to put them at type 2. So some people will say, oh, this is type 2.5, this is type 2.9, this is type 2.0, things like that. So it is a spectrum. It is like a straight line where you transition from one to the other. And it's not like a distinct 1 and a distinct 2 and a distinct 3. So type 1 is the severest form, and it is known as the Wednick-Hoffman disease. For those of us in pediatrics, this is the one we often encounter. They come to us early. Type 2 is intermediate type, and type 3 is the mild type. The truth is that there is also type 0, which is worse than type 1. And type 0, the severity is so bad, onset is in utero, and they are often born either still or they are aborted. So we don't often encounter them. They are not compatible with life, so we don't often have them in clinical diagnosis. But there is a very severe form, which is type 0. And then in much the same way, there is a very mild form, which is type 4. And we don't often encounter that in pediatrics because the onset is in adult life. So our adult colleagues probably will encounter them, but we do not encounter them. So traditionally, the classification of SMA is done clinically. We don't use copy numbers to classify SMA. We use clinical presentation. And the two main parameters that are used are the age at onset of the floppiness, or the age at onset of the weakness, and then the maximum motor development that is achieved. So for type 1, the onset is usually before 6 months. So the parents will tell you that they notice that the child is floppy even before he was 6 months old. And these children, their maximum motor development is that they never sit unsupported. They don't achieve independent sitting. For type 2, the onset is between 6 to 18 months. So these children usually sit because by 6 months they are sitting, and it is only after that the disease will set in. So they are sitting by 6 months, but they never walk. So there's type 2 onset is between 6 to 18 months, but they never walk. With type 3, the onset is after 18 months. And then they do walk. So they attain independent walking at some stage, even though later on they might regress. When it comes to prognosis, type 1 has the worst prognosis because they die within the first year or 2 of life. These days, they are living longer because of current interventions that we'll talk about later on. And then for type 2, they may grow into late childhood. That is from 5 to 12 years. So they might enter 5 to 12 years for type 2. For type 3, they often grow into adulthood. And so you can see that the prognosis correlates well with the severity of the disease. So for children with SMA, the clinical features are that they often have a normal facial expression. They are very alert. They tend to know all that is going on. They don't have facial weakness, unlike congenital myopathy. I will not be able to talk about congenital myopathy, but if you see a child whose face is so weak, the child has weakness even with eyeball movement, think congenital myopathy. Don't think about SMA. SMA, they often do not have facial weakness. And they are very alert and they are very intelligent. And all the things they are not able to do with their muscle, they channel it into their brain power. So sometimes some books even think that cognitively they are superior to other children who are of the same age. And then they also tend to have tongue fasciculation. You see the tongue dancing in their mouth. This is sometimes it's difficult to see, but when you see one, you never forget. So they often tend to have tongue fasciculation. And then the weakness is symmetrical. Left side, right side, weakness is the same, and it is flaccid. The pattern of weakness, remember, it is an anterior horn cell disease. And so the pattern of weakness is more proximal than distal. And the lower limbs are more affected than the upper limbs. One thing about SMA is that the deep tendon reflexes are absent. If you ever examine a child who still has reflexes, you hit the knee jerk and then it jerks. It is not SMA. So the deep tendon reflexes are usually absent in SMA. And then they also have bulbar weakness. So because of the bulbar weakness, they have a weak cry, they have a weak cough, they have pulling of secretions, they have a poor sac, and then they often tend to have recurrent aspiration because of this bulbar weakness. And because of the recurrent aspiration, sometimes all the history you will get is multiple infections, multiple chest infections. And a child in a short life has been to hospital, has been admitted several times with chest infections, and you realize that that is all you have. But when you do a detailed examination before you're able to pick up SMA, and that is because of poor bulbar muscle, weak bulbar muscle, and aspiration rates. They may also have contractures. Of course, if you put one limb down in a particular way for a long time, all of us, and after some time you want to move it, it becomes difficult to move. Because of weakness, their limbs are still, and then they often tend to develop contractures. And then they may have intercostal muscle weakness with relative sparing of the diaphragm, leading to paradoxical breathing, as I explained earlier. And the survival of these children depends on respiratory function. What kills them almost all the time is respiratory infections, chest infections. So their survival depends on respiratory function or bulbar function. So I think I've gone through most of this. I might skip this slide. The history of decreased fetal movement, floppiness at birth, delayed motor milestones, recurrent aspirations. When you examine them, they are floppy, they are cognitively bright, normal facial expression. They have proximal weakness than distal weakness, tongue fasciculation, and their chest may have a bell shape. This is because the diaphragm is continuously being used. And when you use a muscle for a long time, it becomes hypertrophied. That's what people do when they go to the gym and work on their biceps. Their biceps get hypertrophied. So they use their diaphragm a lot. And so the lower part of the chest gets wider. And that gives them what we call a bell-shaped chest. And I've already explained the paradoxical breathing and the contractures. Some of the investigations are that anytime you see a child with neuromuscular weakness, one of the very common investigations you can do is creatine kinase. In SMA, the creatine kinase is usually normal. Even if it is raised, it is mildly raised. I will explain later what I mean by mildly. The upper limit for creatine kinase is some labs will quote 270. So if you have something like 500, even though somebody will get excited that it is almost 2 times the normal, it is not so high when you compare that to what you get in conditions like Duchenne muscular dystrophy, which will present with tens of thousands. Yeah. And then you may do an ECG to look at the heart, not because the heart is involved, but because you are interested in the baseline. I think I have some pictures of baseline fibrillation. I'm so sorry, I didn't put it up. But you are interested in the baseline. So when you have your QRS, your P wave, then QRS wave, they all rise and then they come back to the baseline. And the baseline is supposed to be almost a flat line. But you see that in these children, the baseline is still a swinging or oscillating baseline. So it is still a wave. And it is a very sharp, a fast wave. And we call that baseline fibrillation. So that's the reason why we do ECG. And it is because of the fibrillation of the chest wall, not because of heart lesion. These days, we are doing DNA analysis. We are testing for the mutation in the SMN1, and we can also test for mutations in SMN2 and even copy numbers of SMN2. But traditionally, in the past, they were doing muscle biopsy. These days, nobody does muscle biopsy for SMA because it is quite invasive, and you need so much expertise. You need a pediatrician to make the diagnosis, an anesthetist to put a child to sleep, a surgeon to take the muscle, and then a pathologist to read it. And that is quite a lot and can be very expensive. So we often tend to go with genetic analysis. But if you do muscle biopsy, what you see is that you see muscle atrophy. You can also do EMG. EMG is electromyogram. And we are looking at the strength of the muscle contraction, and it will just show weak muscle contraction. The treatment is mainly supportive, and until recently, we didn't have any specific management. So the treatment has always been supportive. You do physiotherapy, respiratory support. If you can give them non-invasive ventilation like nocturnal BiPAP, and then you do chest physio and cough assist when they have respiratory infection. Because remember, they pull their secretions, and so you have to help them bring out their secretions and also the mucus. And then you have to treat chest infections promptly. There's no point in saying that, oh, this is viral, it will go on it or no. For this patient, this is one of the patients that you break the rules and you treat promptly using oxygen therapy, antibiotics, and then positive pressure ventilation whenever they come in with chest infection. And then, if possible, you have to pass a gastrostomy tube. It reduces the risk of aspiration. Once you pass a gastrostomy tube for feeding, you pass all the feeds through the tube, and then it reduces the risk of aspiration, and then improves their nutrition, and it improves their quality of life to a large extent. Currently, there are 4 genetic modifying drug gene therapies that are on the market for children with SMA. One of them is Zolgensma, which has a long name, and I will not bother you with that long name. Just remember Zolgensma. This one, it is linked to a parvovirus. And then what the virus does is that it goes into viruses have the tendency of entering and altering our DNA. So it goes into your body and it delivers a functional copy of SMN1 to the patient's DNA. So the patient is an SMN1, a functional copy. The patient has an SMN1, but it is a mutant. It's mutated and it's not functional. But a functional copy will be delivered into the patient's gene. And it has been found to be very helpful. There is another one known as nisenicin or Spinraza, which is also on the market. It also increases the SMN protein by increasing the numbers of SMN2 gene. So it also works on the SMN2, increases the copy numbers of SMN2 and thereby decreasing the severity of the disease. Then there is Ridisplam, which is taken oral. It increases the SMN protein levels by also modifying the SMN2 copy numbers. And then more recently, I think as late as, or as early as, was it December last year or so, a new one has been approved. It is known as Itvisma, and it acts just like Zolgensma. And these are all on the market, unfortunately, not available here to us in Ghana and in other third world countries. I've only had one patient on Zolgensma. This is because he was born in the US. He was diagnosed in the US. He was started on Zolgensma. And when they were relocating to Ghana, they were referred to me. That is the only patient I've had on Zolgensma. I've not had any patient on Spinraza, and I've had one patient on Risdiplam. This was donated by is it Roche? Yes, on compassionate grounds. Otherwise, it was going to cause the patient about $140 something thousand every 3 months to get the medication. So it is quite expensive and not available to the ordinary Ghanaian out of pocket. So that will be my talk on SMA. There are quite a number of neuromuscular disorders, but we've already done 1 hour. So I will just pick on a few and quickly run through the slides, and then we can have a discussion. I'm sure the discussions will bring out a lot more information. Poliomyelitis is another neuromuscular disease that affects the anterior horn cell. So whilst SMA affects the anterior horn cell, poliomyelitis also affects the anterior horn cell. The difference here is that SMA is inherited, whilst poliomyelitis is acquired. And poliomyelitis is caused by a virus. There are 3 types, type 1, 2, and 3. It is an enterovirus, which enters the body through the fecal-oral route and then invades the CNS and then settles at the neuromuscular junction and causes the paralysis. It predominantly affects children less than 5 years, but older people could also be affected. And then because of vaccination, there has been a drastic decrease in incidence of polio. Almost every part of the world is free of polio, except pockets of Pakistan and Afghanistan. But there is something called circulating vaccine-derived poliovirus. This is the weak virus. The virus that the vaccine is actually made up of a weak virus that we give orally. The one the babies receive as drops in their mouth. Yes. So it's a weak virus. However, in some instances, it can cause some mild illness, and especially in children who have not had any vaccination. So sometimes we get outbreaks of circulating vaccine-derived poliovirus. So it is not the original virus. It's not the wild poliovirus, type 1, 2, or 3. As for wild poliovirus, if you hear that there is a wild poliovirus, WHO will move in there with all its machinery. If we ever record wild poliovirus in Ghana, I'm sure WHO will come and establish their headquarters in Ghana. So what we often hear in the news is usually vaccine-derived poliovirus. So I've already mentioned that it enters the body through the mouth, gets into the gut, into the it goes into the bloodstream and then attaches to the peripheral nerves, goes up the nerves, and then settles at the neuromuscular junction. So when people get the infection, 90 to 95% of people will not have any symptoms. They get the infection, but they will not even get an illness. They don't have any symptoms. A small percent, like 4 to 8%, will have a fever, a sore throat. They feel ill for a short time, but it is self-limiting, and then they recover. They may not even come to medical notice, or they may not even come for medical attention. Then a small percentage, still about 1 to 2%, will have what we call aseptic meningitis, where they will present with headache, neck stiffness, back pain, leg pain, but they will have no paralysis, and they will recover. Unfortunately, about 1% or less than 1% will have what we call paralytic poliomyelitis. And these are the ones that get paralyzed. They will have usually a unilateral paralysis, but it can also be bilateral. But even if it is bilateral, it is usually not symmetrical. So it can be bilateral and asymmetrical. And the weakness, remember, it's an anterior horn cell disease. So the weakness is more proximal than distal. The legs are more affected than the arms. There is no sensory loss in anterior horn cell disease. There is no sensory loss, as opposed to peripheral nerve disease, where you have sensory loss. In anterior horn cell disease, there is no sensory loss. And remember, the reflexes are significantly reduced or absent. So when you have poliomyelitis, I mean, it's very important that you establish a diagnosis, and you can use stool PCR to isolate the virus, which is the gold standard for diagnosis, or you can take throat swab, but it is less sensitive. You can also take CSF. That is also less sensitive. So stool is the gold standard. And that is why when there is acute flaccid paralysis, public health physicians will always come around and look for stool. If you want to manage the condition, remember it is supportive. There is no antiviral that can cure poliomyelitis. So you do pain management, physiotherapy, respiratory support, you prevent contractures, and then you manage complications, if any. But prevention is mainly on vaccination. So in Ghana, we are still using the OPV, but there are plans to completely replace the OPV with the IPV. The OPV is given orally. It is cheap, easy to administer. You don't need any skill. Any person in rural Ghana can administer it. So that is what is commonly used in low resource countries, but it is the one that is also associated with circulating vaccine-derived poliovirus. So because of that, the WHO is seeking to replace the OPV with IPV. The IPV is inactivated polio vaccine. WHO is seeking to replace the OPV with IPV, so we don't have circulating vaccine-derived poliovirus. But it is expensive. It is difficult to give. You need somebody who is skilled, because remember, it has to be given as an injection. So not anyone can give it. So it has to be a skilled person, and all that are important. In addition to vaccination, improved sanitation and hygiene is key. And then there has to be surveillance for acute flaccid paralysis. So I'll talk about the surveillance, but before then, I don't know whether I still have time to go on. I have Guillain-Barré, myasthenia gravis, and then Duchenne muscular dystrophy to talk about. I thought I was going to do 5 minutes on each of them, but
Yeah, professor, that's why. Please,
so how
have,
many more minutes do I have?
I'll give you 15 more minutes.
15. Okay, fine. Then I think I can finish Guillain-Barré. Okay, so Guillain-Barré syndrome is a disease of the nerve. So it's a peripheral nerve disease. It is not an anterior horn disease. It's not a neuromuscular junction disease. It's not a muscle disease. It is a peripheral nerve disease. And it is commonly due to a condition we call acute inflammatory demyelinating polyneuropathy. All that it means is that it is acute, and it is an inflammation because the muscle is under attack by autoimmune antibodies. Body antibodies that our body produces attack the nerve. And then the part of the nerve that is attacked is the myelin. So remember, the myelin covers the axon, and myelin speeds up the rate of conduction of the impulse. So these antibodies attack the myelin and destroy the myelin. That is why it is known as demyelinating, and it affects multiple nerves. So it is demyelinating polyneuropathy. That is the most common type, but there are other types. Acute axonal neuropathy, as you can see in the name, this one, the antibodies attack the axon itself, not just the myelin. And then you can also have chronic inflammatory demyelinating polyradiculoneuropathy. I won't talk much about that, but it takes a more chronic course. And then what we call the Miller-Fisher syndrome. We'll talk about that some other time at another forum. So let's talk about the common one, which is AIDP. And it is a monophasic disease. It is acute. When we say monophasic, it's only one phase. It doesn't go and come and go and come and go and come. So when you get a disease, it's just one phase. Okay, if it will happen later again, that is completely different. But it rarely recurs. So it's usually one phase. And it's a demyelinating disease. Peripheral nerves are the target of an abnormal immune response. And then there is usually an antecedent viral infection. And people think that it follows the mechanism of molecular mimicry. So what is happening is that the body produces antibodies against some infections, viral infections like respiratory tract infections or gastroenteritis. And then these antibodies identify, after they have done their work, after they have cleared the respiratory tract or the GI infection, they identify the nerves also as foreign, unfortunately, and then they attack the nerves. So sometimes there is an antecedent respiratory tract infection or an antecedent gastroenteritis. Respiratory tract infections are more common. When I use the greater than, I mean more common. So respiratory tract infections are greater than gastroenteritis, or they are more common than gastroenteritis. The disease often has 3 phases. We have what we call the progressive phase, where the patient keeps getting weaker and weaker and weaker, and it rises. Sometimes, most commonly, it's an ascending paralysis. It starts from lower down and comes up. So in that progressive phase, you have a child who will complain of pain in the leg the night before. He goes to sleep, and in the morning, he says, I can't walk, but he can sit up. But he says, I can't walk. And everybody says that, oh, what is this boy doing? But he says, I can't walk. He doesn't look ill, but he says, I can't walk. I have weakness in my lower limbs. Or even if he walks, he has an unsteady gait. And everybody's like, what is this boy doing? By afternoon, the trunk is involved. And so he can't even sit now. And then before, if care is not taken and it involves a respiratory muscle, then he goes into respiratory difficulty. That is the progressive phase. But sometimes it progresses and then it gets arrested and stays in a plateau phase. And it can stay in a plateau phase for up to about 2 weeks or even more. And then after that, it begins to recover. And the recovery is in the reverse as was seen in the progressive phase. So you have recovery phase where the patient comes back to baseline if they are lucky. So you have progressive motor weakness, and then again, they are areflexic. It is ascending most of the time, but in some instances, it may be descending. It is relatively symmetrical because both sides of the body are affected. The weakness progresses rapidly, reaches its least form or the highest form of weakness by 2 to 4 weeks. And then it may be associated with autonomic dysfunction. It is not purely motor. You may have arrhythmias, you may have BP going up, coming down at some point in time, sometimes gastrointestinal dysfunction. You may have facial weakness if in a condition we call Miller-Fisher syndrome. So Miller-Fisher is basically Guillain-Barré with facial nerve involvement. Yeah. And then you may have respiratory paralysis if it keeps rising. It may even progress to bulbar dysfunction, but recovery is usually within 2 to 4 weeks. To diagnose GBS, it is clinical. So don't go about looking for any labs to diagnose GBS. Use your clinical skills. The patient has progressive weakness with areflexia, that is GBS. And then you do investigations only to support your diagnosis and to rule out other differentials. So the investigations you do will include CSF, that is after the first week, CSF for protein and cells. So long ago, when they started using CSF for investigations, they realized that in meningitis, there is increased protein and there is increased cells, and they thought the cells were responsible for the rise in protein, until somebody started realizing that in GBS, even though protein is increased, there is no cell. There are no cells. So what is causing the cells to increase here? So initially, they thought the cells were causing the protein to increase. But in GBS, the proteins are increased, but the cells are low or normal. So they then said that, no, the cells and the proteins are not associated after all. Because in meningitis, they thought they were associated. So in GBS, they coined the term albuminocytologic dissociation, saying that the albumin, which is a protein, and then the cytology or the cells are not associated. So there is a dissociation between the albumin and the cells. So if you see the term albuminocytologic dissociation, it's referring to the cells being low or normal and the protein being increased, and that is often seen in GBS or Guillain-Barré syndrome. And then again, you might want to take stool just because you want to rule out poliomyelitis and then to look for other non-polio enteroviruses. And then you might want to do a nerve conduction study. Remember, this is a disease that affects the nerve. So in places where you can afford it or where they have the facility, you look at the integrity of the nerve by doing a nerve conduction study. And this will help you differentiate between the demyelinating and then the axonal type. I'm not going to go so much into details, but in simple terms, if you have the demyelinating type, because the myelin is responsible for the speed of conduction, the demyelinating type will produce a slow nerve conduction velocity, and the axonal type will produce a decreased amplitude, a more decreased amplitude in the axonal type, even though it might also have a slow nerve conduction velocity, but significantly it has a more decreased amplitude. Other investigations may include blood serology for organisms like Campylobacter, Coxsackie, Mycoplasma, Epstein-Barr, cytomegalovirus, varicella zoster, Borrelia. They may all mimic GBS in one way or the other. If you do MRI, don't do MRI of the brain. Rather do MRI of the spine. But sometimes I see people doing MRI of both the brain and the spine. You won't see anything on the brain. Unless there is bulbar involvement where you see nerve roots at the level of the bulb being highlighting up or lighting up. But normally it is nerve roots in the spine which will light up on contrast when you do MRI. The differential diagnosis for GBS includes so many things like poliomyelitis. You may have other infections from enteroviruses, transverse myelitis. Unfortunately, we can't get time to talk about transverse myelitis. It's one of the very common things that I wish we could. Spinal cord compression, viral myositis, botulinum toxicity, tick paralysis, porphyria, diphtheria. These are all differential diagnoses of GBS. I'd want to talk about this as my final slide, and then I'll conclude so that we can have more questions. So GBS will present as acute flaccid paralysis. Poliomyelitis will also present as acute flaccid paralysis. And because of polio, WHO is so interested in acute flaccid paralysis that whenever any child has acute flaccid paralysis, irrespective of the cause, WHO wants us to screen to be sure that it is not polio. So the term acute flaccid paralysis doesn't refer to one disease. It refers to any child less than 15 years. This is the case definition. Any child less than 15 years who has acute flaccid paralysis, or a person at any age with paralytic illness in whom the clinician suspects polio. I can see that's a very vague definition. You are defining acute flaccid paralysis and you say any child who has acute flaccid paralysis, but I'll try to break it down. So any child who has paralysis and the paralysis is acute. Acute means that it is of sudden onset. Sudden onset doesn't mean there and there and then. It is usually over 72 hours. So that is what we call acute. 72 hours, that is 3 days. So if the paralysis took about 3 days to occur, within 3 days, this child moves from walking to not walking. That is acute. Okay, and then it should be flaccid. If it is rigid, it is not acute flaccid paralysis. If it is stiff, it is not acute flaccid paralysis. It has to be floppy or flaccid. And then there has to be paralysis, which is loss of muscle strength. And I'm sure we all know how to assess muscle strength using the MRC scale. So for a true acute flaccid paralysis, all these three conditions must be present for us to say this is acute flaccid paralysis. And then it should be notified as acute flaccid paralysis. So you must notify the public health unit in your hospital. If there's none in your hospital or in your facility, I'm sure there'll be one at the district hospital, one at the regional hospital. Some way, somehow, you have to notify them that you have a case of acute flaccid paralysis. Disease control officers or public health officers will come to take samples, stool samples for this child. They will take two stool samples, and these two stool samples should be collected 24 hours apart. It cannot be the same day. So this is to increase the yield of them getting the poliovirus in the stool. So 24 hours apart, that is two separate stools. I have seen instances where, because we say we want two separate stools, somebody takes the same stool and puts some in sample bottle A and another in sample bottle B. It's the same stool. It's not two separate stools. It has to be two separate stools, 24 hours apart. And they must be taken within 14 days of onset of the paralysis. This is because this is where the shedding of the virus into the stool is maximum. So after 14 days, usually you won't get the virus or much of the virus in the stool, and the yield becomes very low. So that is very important. Two stool samples, 24 to 48 hours apart, 14 days after onset of, within 14 days after onset of the illness or the paralysis. And this specimen the specimen should be stored below 8 degrees between frozen pack. So you must keep a cold chain, sort of. And then it must be sent to the WHO accredited laboratory within 3 days. And in Ghana, that is the Noguchi Memorial Lab. So wherever the sample is taken from, it must get to Accra to Noguchi within 3 days. And it must be kept for all the 3 days. It must be kept below 8 degrees. This is important so that the virus could be isolated. If this happens, and then you go to the lab and you still don't get the virus, then it's most likely not polio. So even though we do these investigations for all forms of acute flaccid paralysis, our interest is in polio. When you have GBS, the management, I'll talk briefly about that and end it. The management is supportive. So if it involves respiratory muscle, you have to admit the patient to ICU. If it is rising rapidly, you don't wait. You still admit the patient to ICU. In fact, the moment you admit the patient to your emergency ward or to any of your wards, you even inform the ICU that I have a child with GBS. They are aware so that you don't spring a surprise on them at 10 p.m. when everyone is tired, then you push the patient to them. No, let them be aware that you have a patient on your ward with GBS. They will actually come and assess, and then they will tell you what to look for and when to call them again so that they start to intubate. And it is important to intubate if the vital capacity goes less than 15%. And then you can treat with intravenous immunoglobulin. This is very, very important, even though it's expensive. And most of our patients will say they don't have the money for it. It is usually very, very, very important. And if you're able to give IVIG, it truncates the duration of the disease and recovery is earlier. And then you may also do plasma exchange where they have it. We don't have it in Ghana. And then do not use steroids. This is very, very important. It's unfortunate I couldn't talk about transverse myelitis, but it may also present like GBS. But in transverse myelitis, you want to use your steroids, it is okay. But in GBS, when you think this is GBS, do not use steroids. They actually give you some initial improvement, but they tend to prolong the course of the disease, and the patient might not benefit from it. And then again, you have to do physiotherapy. And I already said recovery is in reverse order to the progression. Unfortunately, I will not be able to talk about myasthenia gravis, but it is an autoimmune condition that affects the neuromuscular junction, and it is also quite common. I will also not be able to talk about Duchenne muscular dystrophy. This is an X-linked recessive inheritance disease that affects the muscle. It affects only males, and some females who are carriers only have heart lesions, but by and large, it affects only boys. They tend to have what we call the Gowers maneuver, and then they tend to have calf hypertrophy. And then if you investigate for DMD, Duchenne muscular dystrophy, the one characteristic thing is that the creatine kinase is markedly elevated, very high. If there is anything like very, very high, that is it. I remember I told you the upper limit for creatine kinase is 270 in some labs. It may change in other labs, but every lab has their reference range. If you get a creatine kinase of, say, 800, don't be excited. It is not Duchenne muscular dystrophy. Even though it is about 3 or 4 times the upper limit, don't be excited. In Duchenne muscular dystrophy, the lowest I have seen is 6,000 international units. That's the creatine kinase. And the highest I have seen is 40,000. So, and people say they have even seen more than 40,000. So they are markedly elevated. And remember, they are always boys. And then they tend to have what we call the waddling gait or the wobbling gait. I want us to go back to our warm-up quiz and then have some interactions. So go back to the answers you wrote and let's see whether you got them right or wrong. So we said myasthenia gravis is localized to the neuromuscular junction. That is true. So myasthenia gravis is localized to the neuromuscular junction. Please mark yourself and be honest with your marking. And then we said Guillain-Barré, we are matching it to anterior horn cell. That is false. Guillain-Barré is a disease of the peripheral nerve. It is not a disease of the anterior horn cell. Duchenne muscular dystrophy, matching it to the muscle is true. It's a muscular disease. Spinal muscular atrophy, matching it to the spinal cord is false. It is not a spinal cord disease. It's an anterior horn cell disease. Remember, the anterior horn cell is not a spinal cord. It is a junction between the spinal cord and then the peripheral nerves. Congenital myopathy matched to the muscle is true. We didn't get to talk about that. Charcot-Marie Tooth matched to the peripheral nerve is true. Yes, that is very true. Dermatomyositis matched to the anterior horn cell is false. Dermatomyositis is a muscle disease. It is not an anterior horn cell disease. Poliomyelitis matched to the neuromuscular junction is false. Poliomyelitis is a anterior horn cell disease, not a neuromuscular junction disease. Botulinum toxicity to peripheral nerve is false because botulinum toxicity affects the neuromuscular junction. Paramyotonia congenita, we didn't get to talk about that, but it is true that it is localized to the muscle. So I think I'll end here and then we can have our Q&A session. Thank you very much. Marilyn, you can take over.
Thank you very much, Prof. I remember one of our old professors, Prof. Oliver Comey, you say you've been washed. We have been washed with bleach. Thank you very, very much. So questions. Questions. So I have congratulatory messages. Everybody is very happy, impressed. For those of you asking for the slides, it was live streamed on the PSG YouTube page, so you can go there and watch it over and over again, so that if you need to refer, you can refer. Before we go to our questions, there are two forms that have been posted on the chat page. One is for CPD points. If you want CPD points, you need to fill that Google form and put in your number so that we can get you some CPD points. And then we also need you to evaluate the webinar. So we have two forms there, the CPD points Google form and the evaluation form. Please do well to fill both forms before you leave. So our first question, so somebody wants to know, how long does the SMA patient stay on the gene therapy medications? Prof.
Okay. Yeah, so that's a very good question. It depends on which one you are using. So Zolgensma, for example, is quite invasive. It's given through intrathecal route, and it's given once. Yes, so it's given once within a window, I think before 4 months of age or something. So it's only effective in places where they do newborn screening. That is when they pick the child up before they get to that age, then they give the Zolgensma. I think it's the same with it's Visma. With the others, I do not know much about Nisenisan. It is given, I think that is given frequently, but it is also that is IV or I am IV, yeah. But with the risdiplam, it is oral and it's given daily. That one is an oral suspension and it's given daily. And it's usually for life, for
For life.
the life of the patient. Yeah.
For life. Thank you. Thank you very much. So these patients you got who Roche sponsored, are they sponsoring for life?
Unfortunately, the patient passed. So,
Oh, okay.
yeah, it's so unfortunate because FDA took about 1 year to give us clearance. It
Oh,
was so difficult. So Roche do not want to continue. Yes, they said it's difficult for them
yeah.
because of the challenges with the FDA clearance. But I have another patient who has shown interest. Actually, not that they don't want to continue, not that Roche doesn't want to continue, but the compassionate program has ended. So if a patient needs it, the patient will have to pay out of pocket. And it's difficult. It's difficult for most
Yeah.
patients. I got a patient who is interested, and we are still talking to see if they can give African rates because they are still selling it in Swiss franc. We want them to sell it in Ghana cedis. So we are still talking to see if
Okay.
they can do it. But that is when the patient has time. So this one I'm talking about is SMA type 3. So they are okay, they have time, but then they want to see if when they get on the medication, as the literature has said, we can improve their muscle strength to some extent. But SMA type 1, they don't have time. And so it was unfortunate that the other one we had, who was type 1, it took so long before the medication came. And when the medication came, the child was actually alive.
Oh.
And the child had a medication for 1 month. And within that 1 month, I was even out of country, but the grandmother kept calling me, telling me that the child is doing well. The child is now improving. The muscle strength is now improving. And then some way, somehow, unfortunately, the child had aspiration and passed. Yeah. So even within that 1 month, there was evidence that it was helping according
Working.
to the grandmother. I mean, not I don't have a scientific evidence, but according to the grandmother, there was an improvement in muscle strength. Yes.
Okay. All right. Thank you. Our second question is says that, Prof, in GBS, how many doses of IVIG, intravenous immunoglobulin, should be given and for how long?
Okay, so IVIG basically is one dose, but some people fractionate it into different into two different 2 days. So some may give it for 2 days. Others may give the whole dose over 1 day, over 8 hours. So it's just a single dose. As to whether
Okay.
a repeated dose provides any added benefits, I am not sure. But
Okay.
in theory, it should, because what the IVIG does is to mop up the circulating antibodies. So if the load of antibodies is very high, then higher doses of IVIG will be helpful. But in practice, most people give only the recommended dose, and it's 1. But depending on where you are and which formulary you are looking at, you may give it as a single dose or as 2 doses over 2 days.
Okay. Thank you. Some more questions on GBS. We want to know whether when IVIG is most effective, if the treatment is given 2 weeks after the onset of symptoms, does it still help with the symptoms?
And that is very difficult to tell. I have not come across any studies that are looking at the time the IVIG is given and the outcome. Yes, but I think that the earlier the better, because yes, if they stay in that plateau state for a long time, sometimes they recover but may not come to baseline. Those who recover quickly, often come back to baseline. Those who stay weak and paralyzed for a long time may then have a lot of other conditions besides the GBS, bed sores, contractures, and all other things setting in, which will still impair on their quality of life and prognosis to say. So I think if it can be given early, the better. Usually, and it is of benefit in the progressive phase. That is, you want to prevent the condition from getting to the bulbar stage where they will have to be intubated. So the earlier the better. If you want, you can stop the progressive phase. That is fine. So the IVIG should be given to stop the progressive phase and then to shorten the plateau phase and then to hasten the recovery phase. So I think the earlier the better, but not later when the damage has already been done.
Excellent. Thank you. Still on GBS, can a child in the plateau phase of GBS be discharged home?
Home is not the ideal place to discharge the patient to. The patient can be discharged, but not home. Elsewhere, they have what we call step-down facilities, where you may not have a doctor there 24/7. A doctor may come only once in a day or once in 2 days. Some of these facilities are manned by experienced nurses or physician assistants, or even if they are doctors, they are general practitioners. So you may not have a specialist go there and see every day. The specialist will be mainly in the treatment center, in the teaching center or teaching hospital, tertiary center, or maybe regional hospital. So these step-down facilities will accept the patient because they don't need so much intensive care. And probably all they are doing is physiotherapy and then basic nursing care. So they can go to the step-down facility until they recover. So in some countries, they will never send you home until you have had full recovery. But we don't have such facilities in Ghana. And if we want to keep all our GBS in hospital until full recovery, then we may also be denying other patients hospital bed space. So some way, somehow, here we send them home, sometimes in the plateau phase. But that is not the ideal.
Okay.
But as for the progressive phase, there is no way you should send a patient home when they are in the progressive phase. Yes, when they are in the plateau phase, when they are in the recovery phase, you can send them home. And if you have a step-down facility within the community where they can go, or if you want to send them to a hospital closer to where they live, that is also acceptable. But certainly, it is not ideal to send a patient home when they have not fully recovered.
Great. Thank you very much. Thank you. The YouTube link, Pediatric Society of Ghana YouTube link has been posted. For those of you who want to listen to this presentation again, you can find it on our YouTube link and you can watch it over and over again. The forms for the evaluation and the CPD forms have also been reposted several times. So kindly look in the chat box to see. I think I don't have any more questions, but I have my own questions. Prof, can you say something a little bit about how a young clinician can differentiate between transverse myelitis and some of the other ones like GBS that you've said?
Yes, so unfortunately, we couldn't get to talk about transverse myelitis, but it is also a neuromuscular condition which affects the spine. So that one doesn't affect the lower motor neuron. It affects the upper motor neuron at the level of the spine. So it touches the spine and causes limb weakness. And so the difference between transverse myelitis and GBS is that while GBS presents with acute, ascending weakness or descending weakness, transverse myelitis is a one-time event. It happens and then all of a sudden there's weakness. It doesn't there's no ascending component to it. Then it is symmetrical. GBS is also symmetrical. It is bilateral. GBS is bilateral, but maybe it's asymmetrical. Transverse myelitis is bilateral also. And then in transverse myelitis, one of the key things is that there is sensory involvement. So you may have either loss of fine touch or some paresthesia, some numbness or something. There is sensory involvement. And then it also tends to affect sphincters. So there is sphincter involvement also in transverse myelitis. Sometimes in GBS, there may be sphincter involvement. And when I say sphincter involvement, I'm talking of urinary incontinence and stool incontinence that may come in. It's usually not incontinence per se. What happens is that because of the sphincter involvement, I mean, all of us, we have urine in our bladder now, but we are holding it because our sphincters are fine. If our sphincters are not working well, we will struggle to go to urinate. So you'll be holding the urine. Even when you want to urinate, your sphincters are not relaxing for you to pass the urine. So you may have urinary retention rather. Okay. And so actually what it causes is urinary retention and constipation. And then after prolonged periods of the urinary retention and constipation, there is leakage. And then they solve themselves. So the incontinence is not what the conditions do not cause the incontinence per se. The conditions rather cause the sphincters to malfunction and hold on the urine or the feces for a longer period until there is leakage and then you saw yourself. And that happens in transverse myelitis. In GBS, it is not so common, even though it may occur. Remember, I talked about autonomic dysfunction in GBS.
Yeah.
So these are some of the fine differences between the two. And then after some time, initially they will all present floppy, but after some time, GBS will present with upper motor neuron signs or long tract signs. So the tone will start to increase. They will have Brick's reflexes. Planters will be upgoing, or Babinski will be present, while GBS will not have those things. GBS actually has areflexia. And one of the last things, when GBS, they are recovering, one of the last things that comes back is the reflexes. So in other places, they will say they will send you home when your reflexes have come back, because that is kind of your protection. Your protective mechanism is back. So whilst in transverse myelitis, they have breaks, deep tendon reflexes. In GBS, they are areflexia. So these are some of the differences between transverse myelitis and Guillain-Barré syndrome.
Great.
And the mechanism is for transverse myelitis, it is demyelinating. Yes, in Guillain-Barré, it may also be demyelinating, but it may be a zona. But the thing is, transverse myelitis affects the spine and not the peripheral nerve, whilst GBS affects the peripheral nerves.
Okay, thank you. There's a question that says, in GBS, do they always recover?
Yes, on paper, they should always recover. But in practice, many things can come in to disturb the recovery. Yes. So sometimes we expect that they come back to baseline, but they don't come back to baseline. They don't recover fully. And then other times, because of complications that might be associated with the condition, they may develop contractures, muscle atrophy, bed sores, and stuff like that. And that may also affect their recovery. But in practice, if we act quickly, get IVIG to mop up the circulating antibodies, they should recover.
Okay. Somebody wants to know if you're sure that what you're seeing is GBS, do you still have to alert the public health for the...
Absolutely. Any form of acute flaccid paralysis, you have to call public health. So whether it is GBS, whether you suspect polio, whether you suspect transverse myelitis, whatever form of acute flaccid paralysis, once it is acute, once it is flaccid, and once there is paralysis, you have to alert the public health unit, because what we are doing is we are doing surveillance, and we are trying to tell WHO that we no longer have polio. So you have to be able to test all the children who are presenting with acute flaccid paralysis and be sure that none of them has polio, for you to say that, yes, we don't have polio. it's not only the suspected cases of polio that you are going to test, because what you are proving is that you are proving that you don't have polio. So test all cases of acute flaccid paralysis. Get 0 out of 1,000 cases, then we'll say that, yes, truly you don't have polio. So that is how countries are certified as being polio-free.
Okay, thank you. Then the last question I have here is, do we diagnose SMA in Ghana? And do we have survival to adulthood in the Western and European worlds?
Wow. Okay. Yes, we have so many patients with SMA. In 2022, I think, was it 2022 or so, I published a paper with other colleagues here in Kumasi. At that time, we had 5 cases of SMA. As I'm talking now, in my PIP files, I have 23 patients that I have personally been involved in diagnosing as SMA. So we have cases of SMA in Ghana. Unfortunately, because we don't have gene therapy available, most of our SMA ones are no longer with us, but our SMA 2s, SMA 3s, a lot of them are still alive. So yes, we have SMA in Ghana. And then in the Western world, it's asking if they survive into adulthood. A lot of them are surviving. So that is the beauty of the gene therapy that is currently ongoing. A lot of them are surviving. I've seen many patients with SMA. In fact, and they are the survivors are actually the brains behind advocacy in the Western world. They are doing a lot of advocacy for SMA. Yeah, so a lot of them are surviving. Yeah.
Excellent. So I don't have any more questions in the chat box. And oh, I've just seen another one. Prof, you didn't complete the rest, like, huh?
Sorry, I don't get it.
Yeah, I think the person wants your slides by all means.
Yeah,
Because
no, they are available. They will be available through the recording, isn't it?
yes, they'll be
Yes,
available through
yes,
the
through the
recording.
recording.
Yeah. Okay, thank you. And the link, as I said, has been shared for evaluation and for CPD. Okay, the SMA cases you diagnosed, Prof, were you able to establish consanguinity?
No, we don't have
That was a question
consanguinity as
in
we
SMA.
don't often have consanguinity here as a problem. We hardly find cousins getting married to each other in our part of the world, even though they may be there somewhere, but I've not seen cases of SMA with consanguinity. But as I'm saying, it is a problem in part of the Middle East, where and then also in the Arab world, where some cousins, first cousins actually, get married. Yeah.
Okay, thank you very much. I think, Prof, you've done a yeoman's job for almost 2 hours of talking and lecturing. Thank you very much for all of you. We had almost up to 270 plus people on the call, and it's been a very intensive and insightful and in-depth lecture on neuromuscular disorders. We are very grateful, Prof. Hammond, for honoring us with your big brains. For the Pediatric Society of Ghana, the Neurology Subspecialty Group, we will be coming back next month in July with neuroinfections. So please watch out, watch the space for our next webinar. Please, is there anybody from PSG who has announcements? I saw Genevieve on the call, or Gabby. Please, are there any announcements to make? I don't think so. So we shall end here and have a lovely evening. Okay, no announcements from PSG. Thank you very much, Prof.
Thank you too. Bye-bye.
Bye-bye.